So what I'm going to talk about today is about unenhanced imaging of synovitis using MRI. And as Gareth says, this was part of my NHR fellowship. So I was awarded £400,000 by the National Institute of Research in 2010 to commence my PhD. So first of all, I have to declare I have no conflict of interest, but I do like to thank the National Institute for Health Research for funding my research. So today, what I'd like to talk to you about is about osteoarthritis. I'd like to talk about the role of osteoarthritis role of synovitis rather in osteoarthritis, current imaging techniques that we use looking at osteoarthritis and synovitis, T1 imaging or mapping of synovitis, and future work, where I think this work will actually end up. So osteoarthritis isn't a sexy disease. It's not like cancer and it's not like heart disease, where we see lots of people outside Marks and Spencer's and Sainsbury's asking for donations for their charities. But actually, osteoarthritis is a huge problem, both nationally and internationally. And probability is that most of you will suffer with some kind of osteoarthritis in your life. Trying to get statistics for osteoarthritis is really hard. We can go to the joint registry where we can find out what joints have been put in, but trying to find out other interventions that happened within the NHS is very hard because everything's not so specific. So some of the stats may look quite old in my presentation, but unfortunately there aren't a lot of recent stats. So in England and Wales, in 2006 and 2007, over 60,000 knee replacements were performed, and 94% of these were due to osteoarthritis. And that's a lot, but when we think about what's going to happen in the future with our ageing population and our increasing demographics of people getting slightly larger and becoming more active in some cases, they reckon that in 2035 we will see over 1.25 million knee replacements. So it's not just a cost to the NHS that's a problem, it's actually a cost to society. In 2000, 36 million working days were lost in the UK due to OA, with an incredible £3.2 billion lost in production. And people can't work, so then they have to go and actually go to social services and get a disability living allowance. So you and I are now paying £2.51 billion for patients that cannot work due to osteoarthritis. And then there are also the direct costs of osteoarthritis to the NHS as well. And this is just osteoarthritis of the knee, which was what my project was about. In 2012, we spent over £620 million attributed just to osteoarthritis of the knee. Now, £426 million of that was due to knee replacements, which, you would kind of think about. But remarkably, over £125 million were due to iatrogenic events related to NSAIDs. And basically, that's gastric bleeding because everybody is popping Nurofen. They don't take their protein pump inhibitors and end up with a gastric bleed. So the NHS is paying £125 million as an event that happens due to arthritis, but is not a direct result of arthritis. Historically, we think that osteoarthritis was a disease of older people. We have this vision of the granny walking around bent with a walking stick. And we thought it was just a disease of the bones. And that's because we had x-rays to show what osteoarthritis was. So on an x-ray, we all know what an osteoarthritic knee looks like. It's got some osteophytes, we've lost our joint spacing, but that's all we can see. But now we can actually use different imaging techniques to see what's actually happening inside the joint. And we now know that osteoarthritis is actually a complicated disease, not just of the bones, but involving the whole joint. So it involves all of the ligaments, whether they're your lateral or medial cruciate ligaments, your anterior and posterior cruciate ligaments. It involves articular cartilage. It involves your meniscus, your fatty tissue within the knee here, and articular cartilage as well. And not only that, it actually involves something called synovitis. Now, synovitis is a well-known phenomenon in the rheumatoid world where we look routinely to see what the effect of the synovitis is happening in the joint, because synovitis causes joint erosion. But we weren't aware that synovitis actually happened in patients with osteoarthritis. So synovitis is the inflammatory process that happens of the synovium. And if you're not quite sure what the synovium is the sac that surrounds most of our articular joints, and basically it produces synovial fluid, which is the WD-40 of our joints. We've all got synovial fluid in it, and that allows us to move our joints without creaking. But we get synovitis when we have an inflammatory process that happens inside the joint, whether that's due to osteoarthritis or degeneration, infection, neoplasm, or, oh goodness me, it's gone there. Lost my train of thought there. So synovitis is quite important. There's been a lot of work on synovitis, and it has been seen to correlate with the pain of patients, to actually see what's happening in the knee joint as well, and to look to see whether we can actually use the synovitis as a biomarker to decide how the joint and the disease is actually going to progress. There are lots of ways of imaging synovitis: X-ray, ultrasound, and MRI. X-ray's great, but we don't actually see the synovitis at all. We just see the osteoarthritic joint, and then we can infer that there is synovitis happening. Ultrasound is the most common diagnostic tool that we would use. There's no ionizing radiation. Most hospitals have an ultrasound machine, and it's really good at looking at soft tissue structures. And with the use of Doppler, we can see whether there's any vascularity within the synovitis as well. But unfortunately, ultrasound is very operator dependent, so you can have two people doing the scans and come up with a different result. We're unable to image large joints like hips or big knees because of the penetration of the ultrasound waves. And unfortunately, we can't see bone marrow and bone marrow edema on them. Step-up MRI, again, no ionizing radiation, absolutely amazing for looking at good soft tissue visualization. It's not operator dependent. We can image any joint that we would like, but it's relatively expensive. There are people that cannot have an MRI scan, and there's not a lot of capacity. So unfortunately, I'm not an ultrasonographer, so I apologise profusely now, but my good friend Laura Horton is, and she provided me this image, and I am assured that this is actually the femur here. We've got the quadriceps tendon running across here, and there shouldn't be this big mushy bit here, and that is synovitis. And she's put Doppler on it so that we can actually see that there's actually vascular flow, this little red dot here. Now, I can't tell that, and a lot of clinicians can't see that. And ultrasound's a very real-time imaging technique, so if you haven't done the examination yourself, sometimes it's quite hard to look at other people's images. So the gold standard for imaging synovitis is MRI with intravenous contrast. So to do that, we have to put a needle into a patient's arm, we have to give them gadolinium, and we have to do some form of imaging. So on my left here, we've got a picture of a post-contrast sagittal image of a knee. This patient's had an MRI scan, and it's a T1 weighted image because we've given the patient gadolinium, and everything that's enhanced on this image is synovitis. So we have the suprapatellar pouch, we have the patella, we have the femur, and we have the tibia here. And we see that there's quite good delineation of the synovitis. But we have to give a patient a contrast injection, and not all patients like injections, and not all patients can have the contrast injection. Some people refuse point blankly to have an injection, they're needle phobic. Some people can't have an injection because they've either had chemotherapy or they've had a history of intravenous drug use, and so their venous access is not very good. Some patients are allergic to gadolinium, even though it's not as common as we see in the CT environment, but some patients are not able to have the gadolinium. And more importantly, in the last 10 years, we've now seen this disease called nephrogenic systemic fibrosis, which gadolinium has been directly related to. So patients with poor renal failure or poor hepatic failure are more at risk of getting nephrogenic systemic fibrosis because they're unable to actually eliminate the gadolinium from their body. Nephrogenic systemic fibrosis is a horrible disease and is actually potentially life-threatening. So we could be actually imaging patients with MRI, giving them gadolinium and for a non-fatal disease process, but actually giving them potential for having a fatal disease. So my thesis in 2010 was the Cosmos study, which is a pretty cool study if you ask me, and that's the great thing about doing a research, you've got to get your right acronym. And Cosmos stands for Contrast Obviated Scanning Use of MRI of Synovitis. And basically, I wanted to know, can we find and see synovitis on MRI scans without giving the injection? And thankfully, the National Institute of Health Research thought this was a good idea as well, and I was given a personal fellowship to do my PhD. So after ethical approval, I was able to recruit 83 patients into the clinical arm of my study. I had 50 men and 33 women, and the demographics are a little weird, either because of where I live in Leeds or who was coming through the clinics, because osteoarthritis of the knee is actually more prevalent in the female population than the male population, but in Leeds, for some reason, I got more men. And it was a bit of an iteration process, my study. I wanted to know what we could do, how we can see things, and it was a bit of a strategy as to which plans we were going to go down. So first of all, I started looking at conventional imaging. Is there a way of us looking at synovitis using conventional imaging? Now, people in the audience may say, yes, of course we can, because we have our T2-weighted sensitive images, and we see synovitis and synovial fluid clumped together, and we say that is a synovial burden. But that's not true. You can have synovial fluid without a lot of synovitis, and you can have synovitis without a lot of synovial fluid. So it's a poor man's representation, but does give us some idea that we do have some issue happening within the knee joint. What I looked at was looking at conventional images to see whether we can apply a different technique in looking at them so we could actually see the synovium rather than just seeing this clumped up issue of synovitis and synovium together. So this image number A is your T2 weighted image. We can see here that everything it's fat saturated as well. Sorry for those that don't do MR. So everything that's fat has been saturated out, and anything that's bright in here is synovial fluid. So we can see the synovial fluid sitting in here, and we can see that there is some synovium here as well, that dark black bit. And as I said, we can see bone marrow edema on our images, which we can't see on ultrasound. But where does the synovium begin and end here? We do have fat planes that come between muscle and from tendons and ligaments, but it's not that clear sitting in this front anterior portion of the knee. So this image over here is actually a proton density image, which we've inverted and actually put on the fat images from a Dixon vibe. So a Dixon vibe is a way that we can look at MRI where we get water, fat, combined imaging, and we actually get different sequences, and one of those sequences is a true fat image. So by adding a true fat image to a conventional image, all of a sudden we can see the fat planes that are happening here so that the synovium is a little bit clearer than it is in this image. But it's great, and it was really cool and very sensitive for looking at meniscal tears, but it really didn't answer all the problems that I wanted to do. I then started looking at magnetization transfer. Now, magnetization transfer has been around for a long time. Historically, again, we used it in the brain for increasing the T1 weighting and looking at plaques for MS. But we can put MT on any sequence we want to and in any part of the body we want to. And this is how my story all started. I was actually looking at bone marrow edema, looking at MT, and lo and behold, I could see synovitis. And that was a bit that said, okay, can we see synovitis on these images, and is there a way that we can actually, get rid of the use of using gadolinium? So again, though, this is a magnetization transfer image here, and we can see the synovitis quite nicely up here, but we can't really see what's happening here because it's a pretty grey image, and we've kind of lost all those contrasts between our tissues. But again, if we put fat onto our image, we get some more better delineation. So we can see better delineation between the muscles and synovitis, which has always been an issue. But unfortunately, still around the back here, we can't see what's happening. Diffusion-weighted imaging was the next door that I knocked on. And again, we use it in the neuro world. We have a lovely 3 Tesla scanner up at Chapel Allerton in Leeds, but it's 10 years old now, and unfortunately, it was an MSK brought magnet, so we didn't have all the fancy neuro stuff. So my diffusion-weighted imaging was a bit of a a shocker, but trying to do it on a neuroscanner, which I might do soon, it may give different answers. So the problem with the diffusion weighting imaging that I had was that I wanted to look at water diffusion between going through the synovium, but we just couldn't get the resolution, and we couldn't get the signal-to-noise ratio either. So yes, we can see synovitis. We can see the synovial fluid, which is this bright stuff here. We get to see great minuscule tears again, but actually it was a pretty rubbish sequence and took 15 minutes to do. And so then along came T1 mapping. T1 mapping has historically been used for cardiac imaging, looking for myocardial infarcts. There are lots of different fancy ways for imaging T1 mapping, Locker, Molly, Schmoley, etc., and please don't ask me what they all stand for. But if you go back into our old days in MRI land, we use this thing called variable angle technique, and that's the thing that I decided I was going to concentrate on. So I devised an MR protocol, which was a T1 mapping protocol. It took a year and a half, when I thought it would take 6 months. And we had to make sure that we were actually looking at what we thought was synovitis. So we had to, unfortunately, give our patients gadolinium because we had to use the MR gold standard so that we can compare the images that I got to actually prove that what we were looking at was synovitis. In the ideal world, it would have been lovely to have histology on these patients because that is the definitive way of saying what's synovitis and what isn't synovitis. But even if I was able to take biopsies from all these patients, there's no guarantee that the tissue that we biopsied was actually the tissue that we could see on the images. So that's one of our issues that we have when we do this. But we took the gold standard that we require, we call the gold standard, and that's gadolinium-enhanced MRI. So for anybody that's a bit of an MRI geek, and especially a T1 geek now, this is my protocol. Happy to share it later. And you can do T1 in different ways. And what we want to do is we want to make sure that we have covered any potential reflexivity of the tissue that we're looking at. And to do it with variable flip angles, you need at least 3 flip angles. But by doing 3 flip angles would mean that we were concentrated on such a small range of potential tissue types. And I know that in the knee we have fat and subcutaneous tissue, we have fat in the bone marrow, and we have synovial fluid that because of the bright T2 signal and then the low T1 signal we get on our images, we were going to have both extremes on the T1 world. So I plumped for 5. So we ended up with an image of 5 degrees, an image of 10 degrees, an image of 15 degrees, an image of 20, and an image of 25. And as you can see, as we increase the flip angle, the delineation of soft tissue and contrast increases. And then you can either get yourself a very nice physicist, or you get this software called a CIREX, and lo and behold, you end up with a T1 map. So we had to actually make sure that what the CIREX software was telling us was true. So I had a very nice physicist, and he created a Monte Carlo computer program for me, which took over a day and a half to calculate all my T1 measurements, and a CIREX does in about 3 seconds. But we can say that CIREX does what it says on the can. The other thing we had to think about was, if we're going to do T1 imaging in the knee, what are we going to image these patients in? So those that aren't au fait with the T1 imaging, we need to have a very homogeneous field. And most people would scan their patients, and they would scan their knee patients in a dedicated knee coil. Well, that's great because it holds the patient in the right place. We can make sure that the patient's it's isocenter in the middle of the magnet as we can. But the problem with the knee coil is that it's a transmit and receive coil, and that inherently has a dreadful uniformity of the magnetic field. Now, for those clinical imagers in the room, that doesn't make any difference to you whatsoever. Your images will be what they be. But if you're looking at empirical quantification, it is a nightmare. And so this is one of the experiments I did. We had a Eurospin T1 Phantom, which you can purchase, and they are basically about 20 gel tubes, and they know exactly what the T1 is going to be of these gels at 1.5T, 1T, and 3T. And what was really surprising about this when we looked at it was that the head coil, which is your kind of gold standard coil, was amazing. And so the dark black line is the line that we thought we should be getting with the values. We've got the head coil, we have a small flex coil, we have a cardiac coil, and they all do what we thought they were going to do. They measure the T1 values as we thought they were going to be. But the coil that did the worst was the dedicated transmit and receive knee coil. And that was like a bit of a blow, because it was like, what am I going to do now? I would love to put my patients into a head coil, which is the gold standard coil, but there's nowhere for the rest of the leg to go. And that was a problem. The cardiac coil was also a great idea, but it proved to be a little cumbersome. We have a Siemens Vario, and it was lovely, but you can only plug it into one end of the magnet. So you either had the patient hanging off one end of the magnet and the feet down the other end of the magnet. And again, it just wasn't practical. And trying to get people like in the ISO center into the middle of the scanner didn't work at all. So I actually ended up with the two small flex coils, and they gave us amazing values. The results were exactly the same as the head coil, and it was easy. So we can actually use patients that had big knees or small knees, which again with the knee coil gave us limitations on the size of the knee we could put into the scanner, and it also meant we could get the patients as comfortable as possible, and more importantly, we can get the patient's knee into the middle of the magnet. And then lo and behold, we got some pretty pictures. So this is a picture that we would normally see. So this is an SPGR, which is spoiled gradient echo image with fat saturation on through nearly the midline of the knee. So again, everything that's fat has been saturated, so we can't see any bright signal. So the only bright signal we can see on this image is inflammatory processes or gadolinium going up and down in the popliteal artery. So as you can see, we can see quite nicely here that we can see the synovial fluid, which is the dark liquid. We can see the synovitis. We can actually see the plique sitting in the synovitis as well. And then we look at the T1 image, and so this image required no contrast agent whatsoever, and we get a very similar story. We see the red, which is the synovial fluid. We see the yellow-green, which is your synovitis. Again, we see red on this time for the popliteal artery, because fluid gives us a high T1 signal, so it actually comes up as the same as synovial fluid on this image. But we can see that those patients got synovitis and they have synovial fluid and effusion as well. And it doesn't matter which part of the knee we were looking at. So we've come quite medially here now, so we're very, very far over to the inside of the knee. And yet again, we can see synovial fluid, we can see synovitis, and this patient's had contrast, and we can see some pretty poor bone issues happening here. There's like no contour of the bone here. And because this patient has got an osteochondral defect and has got bone marrow edema, when we give gadolinium, it enhances as well. So we can actually see there's some enhancement here, which is showing some of the degenerative changes that we have either in the femur or in the tibia. So this is my T1 image, and yep, there again we've got the bright red is the synovial fluid. We've got the synovitis showing up around here, and yet we can see that there's some issues happening in the femur and the tibia as well, because the bone marrow, which should be this blue signal because it's blue is fat, has actually been disrupted completely, and we've actually lost all the cortical bone both in the femur, and we've lost cortical bone in the tibia as well. And surprisingly, we can see things on T1 that we kind of thought, well, what's happening on the post-contrast images? And so we said this before, that we take for granted either you have this image of a T2 image where you put all the synovitis and the synovial fluid in together, and then we take for gold that the contrast image is what's really happening. But is it really? Because what we're doing is we're seeing either enhancement or we're seeing diffusion or perfusion of a fluid once you've had that injection. So this is another patient where we've got the patella here, so we're in the midline. Everything bright up here is synovitis, so that's all enhancing. And then we've got this huge area down here. Now, I would say, this was done in under 2 minutes of giving patient contrast agent. So I would say then everything that's actually enhancing should be synovial fluid, synovitis. But actually what's happening here is when we look at the T1 image, red is fluid, and this area here doesn't correlate to synovitis, it actually correlates to synovial fluid. So for some reason, this person is actually perfusing their gadolinium from their synovium into their synovial fluid at a higher rate than we would anticipate. And if we were looking at this to say what is the burden of synovitis for this patient, we would overestimate, because we would say this was synovitis, when actually it's only the outer rim that is synovitis and the middle part is synovial fluid. And then we get some anomalies that happen in MRI land as well. So this is just another one of my patients who came in and agreed to be part of my study. And I look in the suprapatellar pouch here and I think, okay, what's happening here? Do we have synovitis? Does this person have like a really huge plique that's sitting in the suprapatellar pouch? Because again, we go through the old thing again. We've got red as synovial fluid. We've got the yellow-green as your synovitis. And we've got some kind of signal thing happening here. And when we look at the post-contrast image, which is the image over here, it doesn't really give us much more of a clue about what's happening. But when we look at the image, the X-ray image, there's actually a loose body sitting in the suprapatellar pouch. And when we actually go back, this is fat. The yellow and the blue is a fat signal. So this is bone marrow that we're actually seeing. So we're actually imaging bone marrow in an osteophyte loose body that's sitting in the suprapatellar pouch. Whereas if we just looked on the post-contrast image, we would just say that was actually just pure synovitis. With T1, we get to see the whole knee. So not only do we get to see synovitis, we get to see other structures as well. And this is my good friend, the gastric nemus. And so I took a lot of images of the gastric nemus, and we can see what's happening within the gastric nemus. And it's been proven that patients with osteoarthritis of their knee have really poor quads and they have really bad gastric nemuses as well. So we can see what's happening in the gastric nemus. Can this be a biomarker of us actually predicting who's going to have osteoarthritis of the knee? Or can we see it as a result of patients that have had issues with their knee? So this is a midline image, and here again we've got the normal gastric nemus on the T1 images, and it's a very kind of uniform red, yellow, quite high signal images. We look at somebody that's got a really poor atrophic gastric nemus, which we can see on these normal conventional imaging up here. Exactly the same happens here, because what happens in the atrophic image is that we get fat infiltration, and we infer fat infiltration when we look at normal MRI. Sometimes we can actually see this the strand sitting in here, but with T1 imaging we can actually quantify the fat filtration because we were imaging fat itself. So we can maybe find out that patients who haven't quite got to that point where they're having issues with the knee, but by looking at their gastric nemus, we can actually predict who's going to be progress into bad OA. So we get pretty pictures, but you might have heard from I was alluding, we can get a little bit more from this. And T1 imaging, like magnetization transfer imaging, is a quantification type of imaging, and the fact that we can actually get empirical data from it. So yes, we get pretty pictures, and if you glance and you believe what I've said, you'll believe everything I've just said, that these are all synovitis images, and this is normal, and blah, blah, blah. But I can prove that to you by actually proving the numbers, a numbers game. So what I had to do was to do measurements of the T1 of different structures within the knee. Of course, I was looking at synovitis, but I also wanted to look at the medial head of the gastric nemus. I wanted to look at bone marrow. I took the femoral epiphysis as my benchmark. I looked at subcutaneous fat. I looked at articular cartilage in the femoral condyle because it was very easy to see. Tibial articular cartilage is not very good because the way the tibial plateau dips, we were getting a lot of partial voluming, so we ignored that bit. And then we also looked at synovial fluid as well. And when you take all these measurements of the 83 patients and you put them into SPSS and you say, okay, what is the average value for all of these things, you end up with this graph. So synovial fluid ends up with a range of T1 values so that you can put a cursor on any part of anybody that's got a synovial fusion, and it will come up with a value between 2.5 to 8,000 to 650-ish thousand milliseconds. Likewise, the muscle actually came in quite narrow as well, considering we had all these patients that had atrophic muscles. Bone marrow was like as tight could be, plus with subcutaneous fat, which is what we would expect. It's fat. We know that fat's got a T1 of 350 on a 3 Tesla magnet. Articular cartilage also was quite neat and niche, but what I wasn't expecting, and what was quite the revelation of this whole project, was that synovitis was as tight could be as well. And 83 patients had different durations of osteoarthritis. We had fibrotic synovitis, we had inflammatory synovitis, but we don't know what synovitis really is truly. But what was ever happening in these patients came up that we ended up with a very niche range of T1 values for the synovitis. So what does this mean, really? What am I talking about? Well, we can sit there and we can say, okay, I can put, if you have a T1 mapping and I put a cursor on it, I can tell you whether it's normal tissue or abnormal tissue. And I can tell you whether it's muscle or whether it's fat or whether it's an inflammatory process. But what's the important thing is that we can take this T1 value of 1005 milliseconds, and then I can transfer that into an inversion time and get 693 milliseconds. And then lo and behold, we've got an inversion recovery image. So an inversion recovery image is a stir image or an IR image in MR. We use it for poor man's fat sat. We use it for looking at MS plaques again. But what we can do is we can decide that whatever structure that we want to look at, if we tell that inversion recovery image what the T1 of that structure is, it will nullify that signal for us. So therefore, I can tell the signal that I don't want to see anything of a T1 of 1005, and it will give me no signal whatsoever. So what we have here then is that we have the post-contrast MRI again. We have, it's quite a lateral image. We've got the fibular heads coming in here. We've got synovial fluid, and we've got the usual synovitis happening here, or this inflammatory process. But what we've got here now, instead of having the bright or the coloured, we've got this dark line. We've got this line of no signal, which for those of you who are MR people is cortical bone or tendons. We don't get signal from it whatsoever. And I can prove that actually this value comes out as 0. So anything that has a T1 value of 1005 has been completely inverted in this image and then hasn't given me a signal. So then it's not just me saying this is synovitis or this is muscle. It is synovitis because that is the only structure within the knee that gives us that T1 value. Inversion recovery images only take 4.5 minutes, as opposed to the 25 minutes that it took for me to do my T1 measurements. So all of a sudden, we come into a clinical range where potentially we can bring this into our clinical world. And you might say, well, what's the point of doing this on patients with osteoarthritis of the knee? Well, as we said, it's a huge burden on our population. It's a huge burden on both our NHS and our social systems. But if we can use this as some kind of way of either predicting who is going to have these issues and maybe intervene before we get the radiological changes on our X-ray, that could save both the patient and our society a lot of money. Also, we are now giving drugs to these patients. We are starting to go down the rheumatoid arthritis route, where we give chemotherapeutic drugs in small values to these patients. So with the RA patients, it's quite often that we give patients methotrexate. Methotrexate was used to treat lymphoma 20 years ago. We only give them a little bit now, but it still has some horrendous side effects. People lose their hair, they're put on steroids. It's a terrible disease, and we don't really know what happens to the joint. We give it to the patient feels better. We may image them, we may not. We may just image how much we can see of the synovitis, but we don't see what's happening on a cellular level. So if we were to use this in that clinical world, we'd be able to see what is potentially happening to some of these patients, that the methotrexate's not working at all, and so why put them on 6 months drugs that's going to cause them horrendous problems and cause the NHS a huge bill? If it's not working and we see the T1 value of synovitis isn't changing, then let's change the drugs or let's change the intervention. But if it is working and we can see that actually the patient is reporting better outcomes and we're actually getting a biological agreement factor as well, then keep the patient on those drugs. So, in conclusion, yes, you can see synovitis on MRI without giving contrast agents. T1 is amazing, not only that we get pretty pictures, but actually we get empirical data as well. Doing true T1 mapping is a bit of an issue in the fact that you need to have a really homogeneous field, and it takes 25 minutes. But if we go down this line of actually using an inversion recovery image where it will take us 5 minutes, who knows what's around the corner? So I would like to thank the NHR for funding my PhD. I'd like to thank the patients of Chapel Allerton and the staff of Chapel Allerton for donating their time to me, and the staff of the LMBRU for helping me scan these patients. And thank you to the college for letting me share my work with you. Thank you.